Thank you, Dr. Lobach, for your kind words. First of all, I want to thank all of you for being here this morning, and it is going to be a tough act to follow, Professor Goldstein. I gained so much in the last 1 hour that I probably did not get any of that in the University of Pennsylvania by staying there for 6 years. But I'm really very thankful for attending that lecture. I'm almost comparing myself to be a glass of tap water after a great bottle of Cabernet. So, thank you again to Dr. Lobach for putting together this wonderful symposium again. I really enjoyed this and coming here and talking to all of you. I get much more out of this, to be honest with you, than everybody else here. I do have a little bit of ADHD as a surgeon, so I'm going to stand on the podium. I'm going to just walk around with all of you. I always feel better with everybody else here. So my assignment for today is really to talk as to what orthopedics can bring into traumatic brain injury. Next slide, please. Do I have some? Oh, there you go. So these are my disclosures. Nothing really fantastic to be proud about. But these are my real superheroes. Nowadays, all of us go to the superhero movies, Avengers and so on and so forth. But I think these are my true superheroes. And in fact, I want to start by giving a big hand to two of my superheroes who are here. We have made a lot of progress in technology, medicine, science in general. This little iPhone XS in my pocket is phenomenal and is way better than this big room of computer in Philadelphia back in the day when we started. Many of you are guilty of having a Tesla in this room, I guess, and it's an automatic car. We've come a long way in that aspect as well. We've seen a lot and heard a lot about biologics. Right before my talk, I'm not even going to question anything that was said because obviously we are still in an era at this point where we don't know where we are with biologics. But things are evolving rapidly. This is PRP treatment. We don't know the level of evidence or lack thereof with these modalities yet, but things are rapidly evolving in science. And this was the previous talk. The next trillion-dollar industry, possibly the stem cell. In orthopedic surgery, we made several advances already. We are capable at this point of three-dimensional cartilage printing. This is a 3D printed meniscus, which is being transplanted into the human body. I don't think we are too far from getting 3D printed cartilage. I mean, we all know in San Diego itself, you have 3D printed liver cells, 3D printed kidney cells. Lots happening there. But let's go back into history. History is always important. Back in the day, in orthopedics, it's not a very old specialty. 1743, Sir Nicholas Henry first described the subspecialty of orthopedics. Back in the day, Hugh Owen Thomas used to say, you break something, you get infection, inflammation, anything. Immobilize, immobilize, immobilize. Put them in a cast. Put them in a rehab for 3 years. But then came Lucas Champion and said, well, life is motion, and motion is life. And then came internal fixation. It's amazing to see that what seems to be the height of absurdity in one generation becomes the height of wisdom in the other. This is a remarkable slide. This is the first slide of internal fixation in the human body when implants were decided. And Johnson & Johnson bought Synthes for close to $25 billion just about a year and a half ago. So that's where we are with internal fixation today. Standard of care. I hear that word everywhere. Medical legally, generally speaking, standard of care. But what is standard of care? Standard of care has kept changing forever. Back in the day, the standard of care to treat contractures, deformities, infections was, you know what? Amputation. Then came the era where you got something like poliomyelitis, you got something like herpes, you got something like tuberculosis. Somebody would be in the hospital for 2, 3, 4 years. things evolved. Braces came into the picture. Some children with polio could potentially start getting up and possibly walk around a little bit. Things have evolved in orthosis. Things have evolved in wheelchairs. This was not too old, but probably just 5 years ago. And today we have this. Extreme advances in every aspect. I'm going to tell you a few stories. I'm a surgeon. I operate on people for a living. I can only tell stories. This is a young man, approximately 22 years old, was hit by a semi, coma for 3 months, essentially completely crippled, and I'm sure most of you see that aspect of traumatic brain injury. And now he is 2 years post-op, walking completely independently, brace-free. He eventually moved to San Diego because I live here. I've never had that happen. So he now lives in San Diego just so that he could see me for the rest of his life. But amazingly independent person at this point. When he came to me, it was a typical traumatic brain injury posture, left upper right lower extremity involvement. This is another young man, Peter Stroka, a phenomenal brain. He's a mechanical engineer from London, UCL. Was at UTC biking at 4 o'clock in the morning, hits some construction part. Wasn't found till 9 a.m. He was in Scripps Mercy for approximately 2 months in coma. When he came to me, he was completely quadriplegic on a board. And the slide on the right is after Peter's lower extremity deformity correction surgeries. Last year, he actually came to this meeting and stood up in front of everybody. So that was a slide from last year. Can you play that video, please? So Peter's ability now to get up and stand. He may not be jogging in the park right now, but for someone who's completely quadriplegic, like stiff as a board, to be even able to get up and stand without braces, in my opinion, is a humongous achievement from a brain injury standpoint. This is the story of a 17-year-old who actually hadn't walked for 2 years. And we did reconstructive surgeries around his pelvis, hip, knee. This is the first time he's walking out from my consult room in the hallway 2 years later. Reconstructive surgeries, all in his extremities. I think some of you in this room know about this patient. Obviously can't talk about it because of HIPAA. All right, let's go to this person. This is a Haitian who was a construction worker and actually fell from a manhole on top of the construction, coming down 40 feet. Liver, spleen, abdominal, chest, tibia. Essentially, both upper extremities and entire right lower extremity deformities. This was after a series of corrections in his upper extremity. He wanted to scratch his head once. And he was so happy that day because he could sit and actually start scratching after I don't know how many years. So it's just an important aspect to show. But check his abduction in the shoulder at this point. Ability to rotate and actively take his hand up all the way there. After all his deformity corrections, he came outside my office one day to just give me a hug. But what's important to watch is no braces. You don't see any braces in that lower extremity. And functional level has tremendously gone up since the last 2 years. I have a young lady here, Casey, whose story is fairly similar to Peter's. She came to me, Mom will remember the day, just like this, on the gurney, and essentially completely immobile. Traumatic brain injury, similar situation, early 30s, was in coma for months. And Casey's just into treatment for over 12 months at this point, complete deformity correction in the lower extremity, still working on rehabbing. So she's still young in terms of her recovery process, but there she is, able to sit comfortably in a wheelchair. She actually, can you play that video for me, please? On the left. So able to get onto a treadmill and start working on the lower extremity now. So essentially what happens? Botox fails, Baclofen fails, medications fail, stretching fails, braces don't fit or fail. Deformities. The body is mechanical. Muscles are like mathematics. You have dorsiflexors balancing the plantar flexors. You have everters balancing the inverters. When you start getting into spasticity, there's a mechanical imbalance because the equation changes. And therefore you have progressive deformity, joint instability, eventually structural failure, and then arthritis in all the joints that are deformed. So, traumatic brain injury, obviously, as you know, based on all the talks that already have happened so far, leads to spasticity, imbalance, and instability and deformities. How can you attack traumatic brain injury? There's a lot of neurologists in the room who obviously deal with the central nervous system component. And then when you go to the peripheral part of the body, there's only two ways to really address it. One is the nervous system or the nerves, and then you need someone like my dear friend Justin Brown from UCSD who will work on the peripheral nerves. Or then you need an orthopedist who deals with the muscles, myotendinous junctions, and joints. The commonest deformity in traumatic brain injury is a spastic equinomax of the foot. You do get a series of other deformities as well, but that's the most common deformity you get. Because of imbalance, imbalance, imbalance. So what you see on the left is an extreme imbalance between the dorsiflexors, plantar flexors, everters, inverters. And even a subtle stroke patient who has minimal equinus will walk like that. Equinus is the basic problem of gait abnormalities in all these patients. So what do we do for equinus? The era of cutting tendons is gone. We don't do tenotomies. The word tenotomy is actually completely gone from neuromuscular rehabilitation. In fact, if you cut the tendon Achilles, or the local orthopedic surgeon where you work with doesn't do brain injury work and he cuts the tendon Achilles, your patient would never walk again. So cutting is not allowed. Lengthening or myotendinous lengthening is what's done. This is the classic Strayer technique where you lengthen it in the upper calf. Then we do transfers. So we start taking the ones that are spastic and start moving them and make them your friends. Make your enemies your friends in life as well. So you go to, this is a Variscourt, tendon transfers. Professor Marian Keenan and I worked a lot on these transfers back to the East Coast and have modified it to where it is today in terms of technique. But essentially something on the left, post-operatively, goes to what it is on the right. And because you use the spastic muscles to balance the foot, it's an internal brace. You don't need an additional AFO once the patient's healed. So at some point when you get a chance, in fact, Ryan's going to walk for you, but when you get a chance to see, it's all balanced and sitting there. This is a patient 4 years post-op with reconstruction. Active eversion is now possible. In fact, this patient ran in marathon as well. This is my original patient who came last year for this meeting, but watch his AFO on the side right now, because after his reconstructive surgeries, he's able to walk without a brace. Hip adduction tightness. This is a very classic tightness in these patients. Adductor tightness. All this compensatory pelvic tilt and limb length inequality. So we do take care of the adductor tightness with obturator neurectomy and lengthening of the muscles in the groin. And similarly for stiff knee gait. We are orthopedic surgeons, we are carpenters. We basically transfer things to balance them. So this is how I would take a rectus femoris, which is a part of an extensor, and now push it to the back of the knee and make it flexible. So take away the stiff knee gait. A typical case of limited shoulder flexion with tightness, internal rotation, flexion, adduction, contraction of the shoulder. Another similar classic patient. Some of these patients are stuck in that deformity. They cannot even clean their flexion creases. And then you get into ulcerations, fungal infections, hygiene issues. But these can be addressed by myotendinous lengthening. Now watch carefully in these slides because these muscles are lengthened at the myotendinous junction. It's not a tenotomy or cutting of the muscle. And then, 3 months post-op in this particular case, it was completely stuck like this. Active flexion, active abduction, and ability to reach the mouth. Again, I'm playing Hector's case again just to show you what shoulder and elbow reconstruction can do to help in such cases. One interesting problem in TBI population that all of you are almost aware of is heterotop ossification. In fact, if a surgeon in your community or hospital is not trained to deal with HO, pretty much no surgeon wants to get into this. Heterotopic ossification is the bane of surgical practice for non-TBI grade orthopedic surgeons. But interestingly, HO patients do quite well when the HO is excised after its maturity. So at the end of the day, it looks like a fairly aggressive big tumor, and the surgeries are extremely extensive. Long hours, multi-specialty, sometimes need neurosurgeons, vascular surgeons, plastics, but these patients do really well after excising these tumors, or we call the so-called tumors from brain injury. Nerve compression similarly do well with that as well. Before I get into my take home, I want to tell you Ryan's story. Ryan, you want to come up and stand? This young, handsome, 19-year-old was at the time, motorcycle accident. In fact, was on the trach for approximately 3 months. He was in coma for 37 days. And I've known Ryan and his family for about 2 years at this point in time. He has a recurvatum deformity in the knee, but he did have the traditional equinovarus deformity of his ankle and foot, which, as you can see, is brace-free. Can you walk for them, Ryan? The only problem with recurvatum is you cannot treat recurvatum surgically. So you have to continue to protect his knee with a brace which is attached right around his knee. And his shoulder, elbow deformities have been corrected. We've done some fine work on his hand just about 3 weeks ago, so he's still wearing the splint. But as you can see, his fingers are all opened up, and his thumb is in the right spot. So once he goes through his occupational therapy, he should have a tremendous amount of function coming from there. So meaningful change in someone who's that young. And he's in fact launched his own website, launched his own corporation for taking care of traumatic brain injury colleagues and patients. So hopefully all of us know about it and we support him for that. Thank you, Ryan. So understand the deformity. You ought to understand that there is a static component to the deformity and a dynamic component. Sometimes just changing position and being able to sit in a wheelchair is a successful outcome. Not necessarily everybody has to be able to walk and ambulate and run. So address both components. There is a lot of work that could be done in these patients to improve them once especially you hit a wall with the traditional techniques. And very important to have teamwork. I couldn't accomplish, or I couldn't say, I could do any of this work without someone like Dr. Lobatz, other neurologists in this room, there's some neurosurgeons in this room here, occupational therapists, physical therapists, physiatrists, home care workers, braces, and parents. I mean, the amount of investment these parents have, especially the ones who are sitting here as well today, in terms of being compliant and doing things and coming back to appointments and taking them for their rehab is together a successful teamwork. My next slide is going to be probably my last slide, but it's another story of a guy or patient from Iraq who has basically had never walked his whole life. So he came here as an asylum seeker and had complete deformities, spinal cord issues and injury, but deformities from his hip down to his ankle and feet. And I did 11 reconstructions on him. And the next slide should be self-explanatory. Could you play the next slide, please? Oh, sorry, I will do this one. Thank you very much for your attention.
We have plenty of time for questions.
Yes.
Would you ever consider surgical intervention on a TBI patient very severely affected, non-communicative, dependent for all cares, but they develop severe spasticity and/or HO, and they're obviously in pain anytime you move them, and hygiene and caregiving has become extremely difficult?
That's an excellent question, and that was my question back in the day when I went to Mary Ann Keenan for learning all this. And the gist of it is that these patients have trouble with positioning, caring, nursing, because of tremendous amount of deformities. Some of them are not even able to negotiate an elevator or a lift where they sit in the wheelchair because one leg is stuck out somewhere out there. And so, yes, these deformities need to be addressed to make them more positional, possibly not ambulant, but more functional. Because just being able to move that arm from here, which is stuck here with no function, to here, stuck here with no function, is still better because you're able to care. You're able to prevent ulcers, infections, fungal issues, and then cause deterioration of them. So answer to the question is yes, there's a lot of reasons why you would do that. Yes, sir.
A couple parts to this question. With insurance limitations to therapy, what level of therapy do you feel is needed to help your surgeries be successful? And do you have problems dealing with the insurance company to make sure you get approval, or and what do you do to help that process along?
Lucky for me, I've got my manager here, office manager. She deals with insurance. But the short or long answer to that is, at this point in time, we have evolved into a practice which only takes certain insurances. So when a person comes through to our practice, by virtue of the insurances we take, there are no limits on some of the issues that you're talking about. But I get your point. We do have sometimes out-of-state patients that come to San Diego to get this. And I think I don't even get into the case and start treating until I find a family like that, or a family support and involvement, because it's a commitment from all sides. And I think that by teaching the family what to do in terms of therapy, sometimes you can overcome those limitations. But you're right, you're capped off at 18 weeks, or sometimes 12, or maybe sometimes less than that with PT. Sending them to the right place is also very important. If you send them to a regular physical therapy location, I prefer to send them to Scripps Rehab or places which deal with brain injury so that they exactly know what needs to be done in those cases. Is also very helpful and meaningful. There are places in San Diego which will make a brace for my patient within 24 hours, same day. Patient goes in, gets a brace same day. So you cut down the number of visits sometimes by having very efficient people around you to help out. Yes, sir.
You were mentioning you couldn't treat his Rickenbacker.
I'm so sorry.
You were mentioning that you couldn't treat his Rickenbacker on his knee.
Yeah, Rickenbacker of the knee, interestingly from an orthopedic standpoint, has two components. One is the bony component, where the femoral condyle and the tibial condyle, like the angulation has changed, particularly in the younger person. And the second component is the stretching of the posterior knee capsule. Once the posterior knee capsule is stretched, and you have a bony component, you're basically stuck in terms of what you could do, because you will have to do something that will mechanically block the motion of the knee to correct the recovery. So in the interest of preserving motion, the only way in which you can continue to have the patient ambulate is to lock the hinge to prevent hyperextension when he walks. Otherwise, have a free hinge. So he has a hinge knee brace that prevents him from getting beyond zero extension, but allows him to flex. And that's just so that he shouldn't get arthritis in the next 15, 20 years. But there's no surgery I could do. I could correct the recovery in a static component deformity of poliomyelitis with an osteotomy. But I couldn't correct it in PI or CP because of those reasons.
You knew where I was going.
I mean, recovery is in fact a blessing for a polio patient, as you know. It's a hand-to-knee gait. They walk with their triceps. They don't walk with their quadriceps, right? Okay. Yes? Yes?
So you mentioned having worked with an Iraqi student veteran.
Yes.
Can you talk a little bit about the efficacy of osseointegration? I understand it's a fairly new procedure.
Osseointegration as it relates to?
Amputees.
Oh, I have actually not done osseointegrated prosthesis personally. I know about them because I'm on the editorial for the JPJS, but I personally haven't done them, so I don't think I'm the right person to answer. What does she mean by this? The bottom line is prosthesis has gone to an advancement at this point where instead of having a sculpture on top of your amputation area, you can actually put a prosthesis, a metal prosthesis, inside the bone, which integrates like a total hip replacement, and then sticks out of the body, and then essentially you're connected to that. The risks of osseointegration sometimes infection, tremendous. If that thing gets infected, then you're stuck with a big problem. You almost have to amputate the entire hip in those cases.
Thank you.
But that's a great question. That's the next, place for amputees. Anything else? Well, early lunch for you.